I was at Bowdoin College, and I
Mm,
decided at the end of my sophomore year I wanted to go to medical school, but I hadn't taken that
mm,
many classes, pre-med classes. So my advisor said, "Well, go down to Tufts. They have a summer program where you can take." I hadn't taken inorganic chemistry yet, so I went down to Tufts for the summer
mm.
and took inorganic chemistry, so that I could then, catch up on the pre-med requirements. And Zev and I were on the same the same dorm, and I actually still have friends from that summer. We had a
Oh,
great
really?
time. That
Wow.
was yeah, it was back in the day when we were at Tufts undergraduate in Medford, and got a lot of walking in because the T didn't go out that far. So I remember we walked a lot to Steve's Ice Cream and to Harvard Square and all that. But anyway, and then
Wow.
so I kind of lost track of Zev. Then several years ago, several people said, "Oh, this is a great podcast." And I looked at it, I was like, "Oh my gosh, I know this guy from the summer of 19, I don't know what summer that was, 1980-ish, something like that." Um,
Mm,
so
yeah.
so I started listening to him. So his voice is very familiar to me. He won't recognize my voice too much from 40 some odd years ago, 45 years ago. But so anyway, he went to Tufts and went to UPenn Medical School. Also, like I did, obtained his MPH from Harvard, and then practiced
Mhm,
medicine in several different settings, in New
mhm,
York and in Boston, and then
mm,
eventually to North Carolina, and increasingly worked in the area of a clinical transformation of healthcare quality, population health, and the like. So, and then in 2017, he launched a podcast called Creating a New Healthcare. I highly recommend it. Some of you know, I walk around Back Cove most mornings, which takes me an hour, and his podcast gets me around about every week or two. I listen to it. And he interviews people from a variety of places who are doing very innovative work. And so you get introduced to
mm,
these really fascinating people. But
mm.
increasingly, Zev himself is fascinating. He's written a couple of books, including Creating a New Healthcare. I'm sorry, no,
Yeah, on the
Reframing
rolls.
Healthcare, a roadmap for creating disruptive change. A lot of that he's going to be talking about today. Some of the, and then this is his newish book, a new like the last year, Beyond the Walls, which I highly recommend. And for those of you who are at MaineHealth and on 110 Free Street, I do have some extra copies over here. So you're
Mm,
welcome to come in my office and pick up one sometime. We bought like 25 of them a few months ago, and they've been flying off the shelves here. Um, and we've been using as a discussion towards so, and I would also just mention to Zeb that I am a Chief Health Improvement Officer for MaineHealth, a 10 hospital healthcare system in Maine and Carroll County, New Hampshire, and lead what's called the Center for Health Improvement. So we have about 300 team members, and we work at that nexus between public health and healthcare, particularly because in Maine, and as
mm,
well as most of the rest of New England, we don't have statewide, we don't have local health departments, public health departments. So we do a lot of that work. Our nonprofit healthcare system does a lot of that kind of public health work out, particularly in rural areas of the state where there really are no accredited public health departments fully covering it. So a number of the people on this call today are from the Center for Health Improvement. And then there's also some
mm.
other folks from public health, colleagues in public health and healthcare whom I see and think it's so nice to see some of you from across Maine. So thank you so much, Zeb. I know you were extraordinarily busy, including you just took on a new role too, which I didn't mention, but you can mention it. But we are also like others in healthcare, but particularly in this area of public health and healthcare, in that nexus, we are all looking for inspirations and guidance around innovation.
Mm.
So we look forward to hearing some of your lessons that you've learned these last quite a few years, on how to address innovation. So I'm going to toss the baton to you, Zeb. Thank you. And thank you so
Sure.
much for joining us.
Thanks, Dora. It's boy, it's a pleasure seeing you, and I've just been tracking you from afar. So folks, it's great to be with you. I think we're all kind of together in our pursuit of trying to really improve healthcare. And so I'll share a few slides. I'll share my story with you. Hopefully, it'll be informative and hopefully a little bit interesting to you. I am very, very interested though in hearing your thoughts and your questions because I think it's really important. So I'll I've shortened the presentation so it's not a typical, hour-long presentation. I'm going to see if I could actually do it in less than half an hour and happy to go back to any of the material. And but more importantly, I would love to, if it's okay, Dora, to open up this and have more of a conversation and dialogue and really hear your thoughts and in fact the job that I currently have. So I began advising a Medicaid managed care company. It's not exactly that, but close enough. About a year ago, and about half a year ago, was asked to come on board as the full-time CEO. So I've been the chief executive officer of a Medicaid managed care platform, which is really all-consuming. So it's a 7-day week, 7-day a week job, and pretty intense. And it's really exciting though. I actually discovered them because I was at a talk, and one of the folks that was actually part of that company actually came up to me and said, "You really should look at this," and that was the end of that. So I learned a lot. So I don't know, maybe my next job's going to come from this talk, we'll see. But anyway, just can you see the slides? I've moved them off. No, can you see them now?
No,
Oh,
we
really?
can't see them.
Let me just
No,
see.
don't
How
see
about
them
now?
yet.
That's
Don't see them. We had seen them earlier, so
It
Sure.
seems like
Interesting.
maybe you're not sharing your screen.
Yeah, you're
Doesn't-
not sharing anything, it looks.
Let's see. Okay, I'm going to hit share, and I'm going to hit the
I
screen.
know you do so many of these, and I have to tell you, it's such a reassurance that you are also having these problems because
Oh yeah,
do this all the time. And when I struggle like this, I think, oh my gosh, where's
it is
my
what it is.
where's the
How about
20-year-old?
now?
Need them.
Yeah,
Oh,
exactly.
yeah, we
Can
could.
you see it?
Yeah.
Yes.
Oh,
Yeah.
okay, perfect. Okay. Well,
Right.
let's just go with this. Yeah, I'll instead of making excuses, I'll just carry on here. So just say you can see them because I can't. I have to.
I can see them.
I have to impose them over your faces, so I can't see your faces.
We can see
So,
them.
okay, good. Okay, here we go. So I'm going to share with you.
Holy fuck.
Is that? I'm sorry.
Somebody's got their should mute themselves.
Oh, okay. Okay.
I don't.
Yeah.
Sorry.
Yeah. Good idea. So look, the reason we're here, the reason I'm here, the reason I've been doing what I've been doing is there's a serious problem. This was the 2024 report from the Commonwealth Foundation and a bunch of really, really smart people who have been following the state of healthcare in the U.S. compared to other countries. Their last report this past year was called "A Portrait of the Failing U.S. Health System," which in and of itself is, kind of captures the story pretty well. And this was their sort of conclusion. The U.S. continues to be in a class by itself in the underperformance of the healthcare sector. These other countries differ in how they do things, but unlike the U.S., these other countries have all found a way to meet their residents' most basic healthcare needs. Boy, that is a real indictment of the American healthcare system. And if you're familiar with this report, which you can easily Google and find, they have a number of summary graphs, and they really show where we are in our healthcare system along about 9 different parameters or so in terms of access and affordability and equity and disparities and things like that. And we perform. The only thing we're really good at is spending a lot of money on healthcare. And we also check the boxes really well. But other than that, we really score at the bottom of the heap. And this has continued and for years now. So I'm assuming you're all familiar with that. Kaiser Family Foundation puts out those reports, as others as well. And so this is not theoretical. This is quite real. It has ramifications. I've been, increasingly dismayed. I think most of my colleagues who are in the state of being jaded and pretty much have given up. A lot of them, despite 20, 30, 40 years of being in this industry, in this profession, we still right now we're basically in a sort of crisis, if you will. lifespan, health span, as you know, in the US, the only developed nation where you're seeing both of those actually decrease. Disparities and inequities, again, just shocking that they continue to increase and worsen. Obesity, you all know that just this is a crisis. What's fascinating, I've become much more interested in this whole issue of metabolic health lately. I've actually posted a few podcasts on it with physicians, scientists who are the real deal. These are people who spent their careers, publishing, research studies on metabolic health, and it's fascinating how obesity is really not it's a marker. It's a consequence of poor metabolic health, and continues to worsen. Chronic disease, mental health is just really frightening where we're going with that. Healthcare access and affordability. And I gave a talk, a keynote at a state hospital association recently, Missouri Hospital Association, and a few months ago. And at the end of this 2 or 3 days of their annual, meeting, I was speaking as sort of the closer and for the conference, and someone raised their hand at the end and said, so look, what's the most important thing? And I said, the most important thing is the thing that I haven't heard one of you talk about in these past 2 days. And that is the fact that healthcare is unaffordable. And I don't see anything that any of you are doing to make it actually affordable. From my perspective, that is the single biggest problem in American healthcare today, and I'll say more about that. And then the issue of provider burnout and moral injury. I actually published an article in the lay press in 1999 on burnout, 1999 on burnout, and not my own per se, but what I was seeing around me. I'd actually used the Moshlock burnout inventory and had done it in the residency program that I was a teacher in, and also with our attendings, and it was off the chart. And so this is something that's continued to really just bother me, especially as I've held positions where I've had thousands of providers reporting to me the fact that 30, 40, 50, 60% of them are not feeling good about their work. Actually, their work is injurious to their health and to their psyche. That to me is just inexcusable. What it says to me too, and I've been in this business for a long time, and we talk about burnout and we talk about all these programs and how we're going to help the doctors and the nurses, and to me the bottom line is it's misguided. The issue isn't the people. The people for the most part are pretty resilient. I think if you're sifting through medical school and you made it through residency, I think you're pretty resilient. A couple of nights in the ER overnight shift, I think you could handle pretty much anything. So to me, it's actually misguided to point the finger at individuals and say, we have to help you. No, why don't you actually fix the damn system, and we'll be fine. So I find it a bit disingenuous, but that's how I see it. What most people don't realize, and it took me quite a bit of time to come to this understanding, is that the healthcare system is more than just the healthcare system. The cost of healthcare, and this is where I go back to the issue of affordability and the business model of healthcare, the healthcare system has actually destroyed middle America. This was a book, some of you may be familiar with it or familiar with the term deaths of despair, the increasing rate of suicide and depression and drug usage and kind of mid America. And really, the Angus Deaton received. These are two Princeton healthcare economists, and Case and Angus Deaton. Angus, I believe, was the one that received a Nobel Prize in economics. So these are not dummies. They wrote a whole book about how the healthcare system itself has destroyed the labor market for less educated workers. There's a whole economic literature on how healthcare has really degraded wages in America. It's essentially a hidden tax because it's so expensive, and that we know that 45% or so of 50% of healthcare bills are actually paid through employers. It's employer-sponsored healthcare, and because of the cost, those costs are actually the employers don't pick up most of the bill. It's actually transitioned into employee wages, and so there was another book that was more recently published last year, again by two really smart healthcare economists, I forget where they're from. I think Amy Finkelstein might also be at Princeton or Harvard. Einav is on the West Coast, and they same idea. They basically said, "Hey, listen, this is, we talk about this. You may have heard recently a lot of talk about the divide in America, the meritocracy. I don't know that it's so much a meritocracy as much as it is the fact that well, maybe it is, but less educated workers are actually more vulnerable to the rising cost of healthcare and the impact that has had on their salary as well as their employment. And so it's weird, bizarre, but yet, at least according to the experts, the case that healthcare has actually created, the cost of healthcare in the US have actually created the divide we're seeing in our country, which, as you know, we could obviously spend a lot of time talking about what the impact that has had and continues to have right now. And this will be the last slide I share before I start to hopefully get a little bit more positive. This talk won't be all that depressing. Otherwise, I would have handed out some medications beforehand. But this was I belong to the HFMA, the Health Finance Management Association. I'm an advisor, and so I get the opportunity to sit down with CFOs from around the country and learn from them. And we were in a closed session, advisory session a few months ago, and they had done a survey of chief financial officers in healthcare across the country, hospital CFOs mostly. And they asked them a question, 3 questions, and 94% in response to the first question believe that our current healthcare system is unsustainable. So basically, just about every finance officer believes we're on a crash course right now, going nowhere. Half of them believe we're at a tipping point in the next 3 years, and over half believe that there's going to be some revolutionary change in the next few years as a consequence of that. So this is where we are. This is reality. If I wonder like why it is I've spent the past few years doing what I've been doing, why I'm so focused on this area, I hope I've given you enough evidence to say that there is a major problem. It's existential, and we need to do something about it, or something's going to happen. And I'd rather actually at least have some understanding of what's going on and try to have some impact on it. So I had what I call, for those of you who are familiar with the movie, the sci-fi movie from the 1990s, was it? The Matrix, one of my favorite movies. And this guy has this sort of moment where he's just, he's living in sort of in this movie in a dystopian future where the reality is actually not real. And so everyone's sort of in this opaque reality, made up reality. And so he realizes that, and he goes and he looks for a mentor. He finds this mentor, and the guy says to him, "Listen, do you want the truth, or do you want to go back to this non-reality, this fake world you're living in?" And he gives him a red pill or a blue pill. He says, "You choose." And if you choose one, you go back to living the life you lived and be happy in your fictitious world. Or if you want to actually know the truth and go down the rabbit hole, take this other pill. So I had that moment a few years ago, about 14 years ago, and it was really pretty serious for me. And it occurred. There were probably 3 or 4 things that happened, and made me think I can't live in this make-believe world that I work in every day. I really need to understand the truth. So what do I do? There was this is not a movie. This is real life, and I couldn't just take a pill and be transported into reality. So I started to do something bizarre. I picked up my cell phone, and seriously, and I started to call people around the country who seemed to be doing something different. They were divergent thinkers, and they were just doing, they're just thinking differently, doing things differently. They were following that path that I felt was more realistic and more hopeful. And so I called them up, I interviewed them, I recorded the interviews, and then I would transcribe these interviews. It was sort of like a beautiful mind moment, and I would have these interviews literally taped up on my walls in my office, and trying to make connections and try to figure out commonalities and principles and approaches, and so I started to do this. I did dozens and dozens of these things, and then I was talking about them, and people said, "Hey, could could you share these interviews with me? So I was starting to send out MP3 files, audio files, and finally someone said to me, why don't you start a podcast? And I said, that sounds like a wonderful idea. What's a podcast? And they said, look it up. So I looked it up, and I started a podcast about a decade ago, about 9 or so years ago, and have been having a continuous podcast. I think it's the longest lasting healthcare podcast, I think. And I interviewed these people, as Dora was saying. They're just amazing. I mean, it's one of the most hopeful, encouraging, fun, exciting, parts of my entire career, to be able to listen to what these folks are doing. And that was sort of my criteria. It's not just thought leaders. I want to know, how are you creating a new healthcare, which, by the way, is the title of the podcast, Creating a New Healthcare. And so I've had the chance to interview, again, some amazing people, from leaders at CMS, Don Berwick many, many times, executives, entrepreneurs who, some of them, when I met them, were struggling, and some of them now are multi-billionaires as a result of some of the good things they've done. And so it's just been fascinating. And so the first book was Reframing Healthcare, and I realized they all were doing the same thing. They were really reframing. They had a new way of thinking, an orientation. They redefined the problems in that orientation, and they redirected their strategies. And again, hundreds of examples of people doing this. And if you're interested, you can look at the book or listen to a podcast, and you'll basically see that reframing, that roadmap, that way of like, oh, how did you even think about that way? And then the problem changes when you redefine it that way, when you reorient yourself that way. And so, and I'll share, I think, hopefully some of that. And of course, the second book I wrote, it was published, I think, last year, 2023, 24. And this is where I started to see sort of a different pattern, where I started to see sort of a strategy emerge. Well, they all followed the same three strategies. One is they were all sort of humanistic. They had this sense of humanism, which I'll say obviously something more about. They all were using digital technology and really kind of liberating. They really digital as a liberator. And then the business model. This has been the most interesting thing to me in my entire career. And I will say that I think that the solution to the American healthcare system problem is actually not a clinical one, and not a technologic one. I think it is a business model problem. And I think the transformation in American healthcare will largely come through business model transformation. And so I know that's a pretty interesting, bold statement, but I believe that to be completely true. And in fact, the job I'm in right now, the reason I took the role of CEO is that their business model is so radically different, so humanistic, that I thought this is really the answer to a lot of the problem American healthcare. So I actually not only believe it, I actually act on that belief. Humanism, let me say a few words about that. For me, and I've interviewed a lot of folks on the podcast about humanism, it really is about the issue of the racism in healthcare, the sexism, the ageism, the ableism, which is an inequity for people who are disabled, industrialism, treating people like widgets, particularly people inside the industry, and this whole issue of classism we were talking about before. This is what I'm talking about. Humanism is not some, kind of fluffy thing. It's very, very concrete. You can measure these things, and therefore you can manage them. And so this is, what I've been really, really focused on and interested in learning more about. A couple of examples of what I found to be really humanistic endeavors. So there were two guys. There was a doctor and a psychologist who were young attendings at the VA, and I forget which VA system they were in. And the doctor was a primary care doctor, and they were teaching, and they were hearing their residents report out. The residents would go in, see the patient, come back out of the room, report out, and then they would go in as attendings. They were working as a team. They would go back into the room, and they would listen to the patient. And they were surprised that when they talked to the patient, there were issues that the resident hadn't reported. And these issues, in a significant percentage of the visits, the encounters with the individual, the issues had a major impact on the ability to actually, deliver care, but they were ignored. It was like they didn't exist. So they decided to. They were both trained in research, and they decided to research this. So they spent the next few years studying this. They videotaped something like over 6,000 provider patient encounters, and they started to create a different code, and they call these things contextual barriers. And so they started, and this is you might be looking at this and saying, well, this sounds like the social determinants of health. Not really. The social determinants of health are a bit more macro. These were micro things. These were daily life issues, like my caretaker just got fired or just moved, or my daughter who was taking care of me no longer lives with me, or I just ran out of money, or issues around attitude towards providers or towards the healthcare system, or attitudes towards illness. And so it's not like rocket science, but they started to codify these again in a very rigorous scientific way. They've published numerous journal articles as well as books on this topic, and so they were really trying to, in a sense, humanize healthcare. Really understand, identify, address the issues that have a big impact on whether someone will either be able to take care of themselves or be able to receive health care. And so even the issue of like depression, like we send people home from the hospital, and we know from the literature that depending on what they went through, the prevalence of depression, especially post-surgery or post-severe chronic disease or this or that, is huge. Anxiety and depression, and yet it's not. And think about it. You're sending someone home. They're debilitated physically. They're not feeling well physically. They're weakened. They've lost muscle mass. They probably haven't eaten or slept. It's almost like they've been in some sort of torture situation, and on top of that, they're in a quasi major depression or anxiety state. And then we just give them a set of instructions and expect they're like nothing's wrong. It's like you just handed them a shopping list, and they're going to go home and do it. It's ludicrous, and yet that's the state of medical care. Now, again, I'm overstating it somewhat, but not that much. And so they were going along, these two clinicians, and then they met a company, some technologists who were very interested in their work, and they basically attached an AI platform. So the care managers or clinicians in speaking with these patients, the AI actually picks up on the language and identifies these hidden contextual barriers to care, notifies the care manager, case manager, whoever literally is talking to the patient, and will identify these things and actually provide solutions. And so it's really fascinating how, again, remember what I showed you, that picture of the humanism, the business model, and the digital, and you start to see how, as I'm listening to these people, I'm beginning to see how they're all sort of following the same set of strategies. I'm going to move quickly through this. I just want to give you some examples. The VA, they have a whole health initiative. Some of you may be familiar with it. You could look it up if you go to va.gov/whole health. Fascinating. And the whole thing came about. Fundamentally, the question they wanted to engage their patients with was not like what's wrong with you or what's your problem or what's bothering you, which is an important question to ask, obviously, but the question they really wanted to get to is what's important to you. And there's a whole literature around why that question is so critical. I mean, at a very practical level, if you're dealing with something like, let's say, just let's pick something like you're getting divorced, or your child is in trouble or something like that, I can talk to you about your blood pressure and changing your medications, or changing, or losing weight or doing whatnot, but that's not what matters to you at the moment. And so, in terms of your whole health, right? What matters to you at the moment is really what I need to address first and foremost, and then we can see what we can do about that, and then we can move forward. So fascinating. That question is just the cornerstone, but it is an entire body of work that they, at least the last time I checked with them, they were trying to spread across the nation in all of their centers and embed in their electronic medical record, and they have training programs to to train teams on how to deliver this whole health care. And some evidence they were accumulating. Again, these are researchers who were launching this. Some evidence that it's actually having some impact in terms of outcomes. The last one I'll share with you about humanism. Again, it's bizarre to me that the VA. I worked in the VA, by the way, for the first 6 years of my career. I was at the Bronx VA. I was initially doing research there as part of my residency. I was going to go into cardiology, so I was doing heart failure research, and then decided not to go into cardiology, and so I was at the VA for 6 years, and running the Bronx VA's ambulatory division, and but where they've come is really interesting. They have a trust index, and again, you could look this up. Every quarter they publish it. It's literally they publish their trust index, so you can see how tens of thousands of veterans respond to these three questions. Do you trust the VA to deliver care that you deserve, right? The next three, do we make it easy to get care? Did we address the issues you wanted addressed? And, do we treat you with respect? Those are the three questions. And again, they look at, they divide it up by demographics, male, female, different, along ethnic and racial lines. It's really, a great body of work. And off of that, they're making changes to really humanize healthcare. So there's so much we could talk about in this humanism mode. Again, going back to racism, sexism, and ageism in healthcare, and ableism and classism. But just wanted to give you some examples of how some folks are trying to address this. And so then going on to digital, obviously I think we're all kind of familiar with that. But real revolution here. Love this quote by Andy Jassy. He's the CEO of Amazon, and someone said, why is Amazon getting into healthcare? At a internal meeting he was holding, I think a organization-wide meeting, and this got put into the press, the lay press. But he said, listen, we're in healthcare because 10 years from now, it's going to be so different. The way we think, we see doctors now will seem almost like historical, right? And we want to be part of that future. So he sees the vision of how digital is going to transform. Robbie Pearl was the president and CEO of Kaiser Permanente for 18 years. He's a plastic surgeon. He's a professor at Stanford. I believe he still practices medicine, and he's just unique. Written a bunch of books. He's retired now. He's written, I think, 3 books, and this was one of his books, recent books, where he really delves into artificial intelligence. And I'll tell you one thing about this that really shocked me. The pace of change of AI is something that has never existed in the history. I mean, it's just never existed. It is improving at a pace where, and he makes this analogy. Imagine if you bought a car, let's say you leased a car for 5 years, and 5 years is up, and you go back to get a new car to lease, and instead of a car, they no longer make cars. Now they make rocket ships, and you have to lease a rocket ship. That is literally the pace that AI is improving. It's almost incomprehensible how fast it's actually getting. And so the idea is, he's like, you can't ignore it. We don't have any other choice. You have to jump into it. You have to embrace it. You have to learn about it. He said to me, Zeb, are you using ChatGPT? And I said, no. He said, you're going to be a dinosaur in like 2 years. And so, I use ChatGPT because, and my children help me with it. In fact, my son was just showing me how to put in graphs and charts into ChatGPT last night, and have them analyzed by ChatGPT. Now, again, lots of problems, lots of issues. I've sat on lots of panels about this, understand it. But the point, I think, Evie Cunningham, who's chief of virtual care and digital health at Providence on the West Coast, she's an OB-GYN doctor, amazing young physician. She said, listen, Zev, this is in one of the podcast interviews I did with her. We're on an unsustainable course, and literally virtual and digital is our way into the future. And so for me at this point, I don't know that there's anything, I don't even know that there's anything we can call digital health, because for all intents and purposes, everything we do in healthcare is digital, or it's digitally enabled. And I was just talking to the president of the Mayo Clinic platform, John Halamka, who's an ED doctor, was the CIO at Beth Israel, and now is at the Mayo Clinic running their platform, their digital. Well, he's running the Mayo Clinic platform, and you listen to him talk, and what they're doing is almost science fiction. And so, and he points out the same thing. There's very little in healthcare you could do now that is not digitally enabled. It's almost unfathomable. He actually thinks in a couple of years it would be malpractice not to be digitally enabled. And again, that's Dr. John Halamka saying that, but I take it with a grain of salt because that's what he does. But still, it gives you a sense of where we are. I love this Geron technologist. I don't know how many of you are familiar with this. This is a lady, I believe she's actually lives in Israel. She's published on the age tech revolution, particularly in elder care. And every year she puts out something like this, which shows all the companies that are using digital technology and now increasingly AI to improve care for the elderly. And it is really, really remarkable when you start to read what she puts out. And I can't quite see her name there, but if you look up Geron technologist, you'll see her work, and she's pretty public about it. 98.6, I was blown away when I saw this company, and I interviewed them, but I also got a demo of their work. I mean, you get on. The machine learning takes your history, connects it to your chart, basically writes the note for the provider, pulls in labs, will ask you questions, and the provider gets on. And this is all virtual, completely virtual, and will kind of look at it. The providers are actually able to see 2 or 3 patients simultaneously. And some of their visits literally last 2 minutes. And again, some of this is, stuff that can go quickly, like someone with a UTI or something like that. But still, it's really, really impressive how the machine is enabling of the provider doing things that you and I would take minutes for each visit, literally eliminated by the machine. This is also a fascinating company, IBIS. The stories here, by the way, I haven't really shared the human side of these stories. This is a woman who is actually an artificial intelligence guru. She worked in the Defense Department. She's MIT trained. She's got a PhD in machine learning from MIT. She spent 20 years or 30 years in the Defense Department. God knows what she was doing. Obviously, she can't talk about it. And then her father-in-law got sick and died in a hospital in Boston. And then her husband got sick and died in a hospital in Boston. And she saw what it was like to take care of an older person in the home. And so she basically applied her, she's actually a physicist originally. That's her PhD. Her doctorate from MIT was in physics many years ago. And she basically created this thing for this artificial intelligence coach for elderly people in the home. You basically get a package. It's like an Apple package. It has a little, an iPad. It's got some peripherals. You set it up. It's really easy to set up, and it basically becomes your health coach, your health partner. It becomes almost like a daughter in terms of it asks you questions multiple times a day, checks on how you're feeling, your mood, your physical activity. Obviously, the peripherals can track some of that as well. And it's there for you if you have any questions. It reminds you about your medications, your diet. It connects you to your doctor. It has your action plan on. It's just a great system. The thing that's really amazing about it, though, is it creates a digital twin. So it's the artificial intelligence is actually tracking you as an individual, and it's looking at your mood. It's looking at other parameters, all the parameters, labs, etc., on you. Physical activity, movement, your eating, your medication taking, and it creates a so-called digital twin. This is Zev. This is how Zev is according to its parameters. And again, it's an artificial intelligence machine, so it's actually doing more than just, it's creating a second Zev. And what's amazing is, as soon as it starts to get information that is not consistent with who Zev is, it starts to raise alarm bells. And so this device, these digital twins, can pick up things like heart failure days ahead of time. It can pick up, things like mood, like if you're, if you're, starting to drink again, or, if you're an alcoholic, it literally will be able to pick up things way before any human could detect them and start to intervene ahead of time, preventing, things like ED visits. And she's got some interesting data in terms of hospitalizations being reduced, inpatient days, readmissions, et cetera. It's just, and she is such a Pia, who is the physicist. She's just such a lovely human being. And by the way, so you see the digital, you see the humanism, and then you ask about the business model. So she's basically giving this away for free. You can take her technology, her platform, and not pay her one penny. She actually has figured out how to bill Medicare for all of this. And not only was she, I mean, when I say she's figured it out, she literally every 6 months, when CMS puts out a 3-inch book on telehealth coding, she actually reads the entire book. I mean, it's a little ridiculous, but she has figured out all the codes, all the subcodes, and programmed it in. So she can make money doing this. She doesn't have to charge you or the health plan. And in fact, she will share her revenue. So again, that strategy I was talking about, the humanism, the digital technology, and the business model all together. People say, is digital going to make healthcare less human, less empathetic? And every expert I've talked to has said completely the opposite. Eric Topol, who I think most of us are familiar with, has written a couple of books about this. And he's like, no, you're missing the point. It's going to take all the drudgery. It's going to take all the stuff that's really keeping us from being human beings. A provider looking into a patient's eyes, listening, talking about the things that matter to the patient, engaging in the things that a human interaction should be, and removing all the stuff that the machine can do. So all the experts have said to me, Zev, if you don't get it, digital is actually the liberator. It's actually gonna do all the things we want it to do to help us. At least that's what I'm getting from all the experts. And the last thing I'll say about the digital before I do a couple of slides on the last point and wrap up is that this is the other part of the joke that we can't miss. The competition in the future, and this is probably true in other industries, but absolutely true in healthcare. You are not, as a hospital system, as a provider group, as an individual provider, you are not going to be competing against another human being. You're going to be competing with another human being that is being augmented by artificial intelligence. That is already happening. And you will not walk into an operating suite unless that surgeon is AI enabled. You won't. And so you won't go to a doctor that isn't AI enabled. It just won't make any sense anymore. So, John Halamka would tell me and tell you and I that that's going to happen in 2 years. Robbie Pearl will say it's going to happen in 2 years. I don't know that it's going to happen in 2 years, but it'll be less than 10 years. And so probably less than 5 years. And so, and as I'm seeing the adoption of even things like AI scribing, it's really interesting to see how that transformation, because I still have colleagues who are like, well, I don't, I'm using Dragon. I don't need AI, I still hear that, see that. And yet it's, I see the adoption happening. It's just very interesting to see that wave, but it goes obviously even far beyond the scribing part of it as well. A lot of the value, of course, is going to be in the back end thing. And the other thing too is you're going to be at a disadvantage. You and I are going to be at a disadvantage if we're not using it in our organization. So for example, I don't want to get too contentious here or raise your blood pressure, but prior authorizations, all this stuff is done by the health plans, right? And again, I have a bias about it. I think it's actually to put off care. A lot of necessary care is being put off by the health plans because they keep the money, and the money's in the bank, or they're investing and they're making money. The longer they can keep it. By the way, they know most people won't contest it. So that's a whole other topic. I don't want to get into, because we could really, get it really upset and angry about that. But they're using artificial intelligence. I think we have to use artificial intelligence too. We're at a disadvantage if we don't. So, I really think, again, it's critical. Finally, just a couple of words about the business model. I do actually think this is, for me, the most exciting thing. In fact, I'm probably going to start to focus my podcast much more on understanding, following the money, essentially. What is the revenue model? How do you make money? I've actually, I don't think I put this into my second book, but it'll probably go into my third book, if that happens. But if you really wanted to change healthcare, what I would do really quickly is I would make every C-suite, their bonuses, transparent. I would publish what C-suite people are being bonused on in hospital systems, insurance companies, brokerage firms, pharmaceutical companies. If you really want to know what's going on, look at where the bonuses, the C-suite people, look at what they're being bonused on. And are they being bonused on clinical outcomes? Maybe. I would suspect 5%, 10%. Where is most of their bonus? That's going to tell you where the money's going. That's going to tell you what the business model is. And if you want to fix it, all you have to do is change their bonus structure. I guarantee you, overnight, American healthcare would change. If you gave me the ability to change the bonus structures for the C-suite people and all stakeholders in America, it would take me a week to transform American healthcare. So maybe a little longer than a week. The really exciting business model revolutions I think are in some of the real partnerships that are happening, the collaborations, platforms, and I'll say a word about that, are really, really interesting. And of course, payment, as I was just sharing with you, the whole issue of alignment of incentives. How are you making your money, right? I have no problem with, and I don't suspect most people do in America and the US, I don't have a problem with people making money. That's not the issue. The question is, how are you making your money? And that's really the problem, because I think it's misguided. I'm certain it's misguided in American healthcare. Platforms. Platforms are, Amazon's a platform. A platform is a business model where you're actually not producing. You don't make money by taking resources, doing something to them and selling them. That's not the business model. A platform is you set up a platform. Think about like a market, like an outdoor market. Like, I think about Italy, right? Or I don't know if you have like a market in your town where, you have vendors come, like a farmer's market. You have vendors come, they set up their shop out of the back of their trucks or whatever, and then you have customers come. And that thing is that marketplace is essentially, it's a platform. Amazon essentially is a virtual marketplace. Uber is a virtual marketplace. Uber doesn't make cars. It doesn't own cars. There's lots of examples of that outside of healthcare, of that sort of marketplace, and they've taken over, right? I mean, they've really taken over the hotel industry, VBROs, et cetera. They don't own hotel rooms. They don't own real estate. They partner, right? They're a marketplace for, I want a room somewhere, and they have people who have the rooms, and they just connect us. So that actually is happening now in healthcare. Amazon, of course, is still the perfect example of a platform revolution in healthcare, where they're basically putting all kinds of healthcare services. Of course, now they own One Medical, Iora Health, but for years they've been having white labeled virtual healthcare platforms like Wheel and SteadyMD and CureAI and Alpha. Obviously, they have PillPack, on and on and on. So they're really developing. They're the largest platform in healthcare that exists today. There are others that are trying to become platforms, and there is this sort of, we're essentially, anyway, that I'll leave it at that. Partnerships are really exciting to me. We in the past have been acting pretty much like in the dark ages, like little fiefdoms, right? With stone walls around us and moats around us. I work in my hospital, you want to get into my hospital system, literally you have to cross a moat with alligators, and I've got people with arrows going to shoot you. And, the idea that we would actually communicate or work together, have commerce together, that is a Renaissance concept that's only recently, emerged in healthcare. And you're seeing some really, really interesting partnerships, particularly between hospital systems and venture capital. Rightmove was a venture capital. Basically, they wanted to do virtual physical therapy. They knew that they couldn't do it themselves within the Hospital for Special Surgery in Manhattan, obviously one of the premier orthopedic hospitals in the country. They couldn't do it, so they basically outsourced it. They created a separate company. They brought in a VC firm that knows how to do startups, and they did a startup. They hired people outside, and they own it, but along with the VC firms. But a really interesting thing, a way to not disrupt their core business, to not compete internally. And in fact, they didn't put any money into it because they just raised funds from their Series A. They raised $20 million. Flare Capital did for them. And so really, really interesting a prestigious hospital system partnering with a VC firm to raise money for a company to provide care, not just locally in New York or Manhattan, but literally across the country and across the world. Hartford Healthcare has been partnering also with VC firms to bring innovations into its shop. It's a multi-hospital system. You're probably familiar with it. General Catalyst buying healthcare systems. Risant, super interesting. Kaiser Permanente been trying to go national, trying to extend value-based care across the country, unsuccessful, and then they formed this company called Risant, and they essentially buy Geisinger, and Geisinger is sort of like the alpha model of what they're trying to create. And I think they've either purchased Cone Health in North Carolina, or they're going to, and they're basically trying to create this, purchase hospital systems and then modify them so they're more value-based along the lines of a Kaiser, more capitated, or a Geisinger. Really, although Geisinger is not fully capitated, but really interesting business model, right? Partnerships, collaborations. Before I left Atrium Health, I was there for 12 years, now called Advocate Health. And my last role, I was chief medical officer there for a while in the ambulatory division, and then senior medical director of population health for a few years. And my last role was really clinical transformation for about 3-4 years. And we formed a partnership with Best Buy where they had the technology, they had the Geek Squad. They had actually spent $2 billion on home care technology, and we partnered with them and essentially formed a home-based care ecosystem. When I left a year and a half or so ago, we had the largest home-based care system in the country, the largest hospital at home in the country. And that was because we partnered with Best Buy. So really interesting. Other sort of novel things that are happening, and I'll just stop here, but Civica RX, again, bringing medications, saying, hey, we're not going to depend on the pharmacies and PBMs. We'll create our own medications, multi hospital thing. It's the actual business model there is very fascinating because no one owns it. It's actually not an owned entity. So you can't sell it, which was the intention, and that was the intent of the people who founded it. They wanted it to be for the people, not for any entity. So really interesting. Again, it's the business model really is what fascinates me about that. So let me just sort of end with, I think summarizing it, I think the disruptions are going to come, as I mentioned, digitally. Another thing that's sort of like for me a duh, and I'm sort of biased here because I spent over 20 years as a primary care physician. I taught internal medicine and residency programs, so I'm a little biased, I'll admit it. But I think the literature is really clear. I mean, this is not new stuff and not shocking stuff, that if you want to improve health outcomes and you want to lower the cost of care, you need more primary care. Putting more cardiologists in a town will get you more cardiac interventions, but not necessarily healthier people and lower cost care. And so but this is somehow lost. I just spent 2 days at the state capitol in Pennsylvania talking to senators and representatives in Pennsylvania, and they were, I mean, it was like, it was weird. I mean, when I said to them, you're talking about rural hospitals and hospital systems, and I get that. I understand they're important, but you're not talking about what really will change healthcare in Pennsylvania, which is primary care. And, and I said to them quite, I just was straightforward. I said, listen, if you really want to do something worthwhile, just change the hospitals to a primary care center. I'm not saying we couldn't have specialties or even a small, surgery and ED, of course, but make it a primary care center and you'll see healthcare change in the community. And so, wellness and lifestyle medicine, we haven't talked at all about that, the whole metabolic health issue. I have a lot to say about that, and I'm learning. I've become much more of a student of that. I think as you get older, you start to, it becomes more important. Your body is less forgiving, and so there's a personal part to that as well for me. Disparities and inequities, it's shameful in the greatest country in the world that we have this divide where literally in every great city, the difference in lifespan could be 15, 20, 25 years, literally people living a mile away from each other. If you're Black and poor, you'll die in your 60s. If you're white and a little wealthier, you'll live into your 80s or 90s, and you literally live half a mile or a mile away from each other. We essentially have third world country healthcare in surrounding and in all of our great cities in the country. It's just when you stop to think about it, it's just shocking, and it's not necessary. We have the ability to reverse that. And then again, I think finally, the fundamental issue in healthcare is we're not paid to keep people healthy. Shocking. And yet, true. And so I really think we need to change our incentive model, change our payment model. I'm not saying it has to be full capitation, but I do believe that there's another argument here too, which we have to understand, which I've only learned in the last few months. We have insurance, health insurance. One of the most fundamental principles of health insurance, going back to Lloyd's of London, is that you only insure, the mathematics only works if the frequency of what you're insuring for is less than 15%. It has to be a low, like dying, right? So your chance of dying this year is less than 1%. You want to get life insurance. It makes sense. Your chance of getting into a car accident, very low also. Even if you're a teenager, male, still relatively low. You buy, car insurance, house insurance, something happening, your roof falling in, really low frequency. Where insurance falls apart, the actual formula falls apart, is when you start to have things that have a prevalence that are over 10 or 15%. And essentially then you're paying multiples. It would be like, could you imagine going to buy a car and you buy the car and then the car salesman says, oh, by the way, we have this new thing, it's called gasoline insurance. And you're scratching your head and you're like, well, I know I have to buy gasoline every 2 weeks or so. And I kind of know it costs me about $60 to fill up the tank. And so how does having insurance help me? And oh, by the way, the insurance costs 5 times what it would cost to just buy the gas. Well, that's essentially American healthcare. We know we should have a primary care appointment at least once a year. We know in a population, you're going to have a certain number of people who are going to need certain amount of things done. Why in God's name would you insure that? You know you're going to need it. Just pay for it. And so we could probably carve out. Now, do you know you're going to get cancer? Do you know you're going to be in a trauma? There are things you don't know. That's what catastrophic insurance is for. But why don't you just insure that and just do direct payment for everything else? And that essentially is sort of this hybrid capitation model, which I think makes a lot of sense. And actually, the company I'm working in right now uses that to lower care by about 50%. We have another couple of other things we do, but it's a really, I had never realized that. I'd never studied insurance or how it works, but the idea that we insure all of healthcare literally violates the basic principles and mathematics of insurance. Welcome to American healthcare. Anyway, I'll end there. I just want to say to you all, my wife's a physician. She's an ID doctor. I practiced for many years. My brother's a doctor. Most of my friends are doctors. I know how hard it is. A lot of friends of mine are nurses. I know how hard it is to do what you do every day, whether you see patients directly or you support those. And so if you remember nothing else, I just want to say thank you. You don't get thanked enough for what you do. I know that's not why you do it, but you should be thanked, because it's hard work and it's really, really important work.
Oh my gosh,
All
thank you.
Saturday.
This was fantastic. Oh my goodness, thank you so much. Why don't we, if you stop sharing, then we can at least go. I know some people have had to drop off because they had another meeting at 1, but if you don't mind, just that was a fascinating talk. I could just listen to you all afternoon. So thank you so much. I'm so grateful for your time. Anybody have any particular pressing questions that they'd like to ask Dr. Neuwirth? And I will just also put in a plug the fact that, we do, as you know, only about 85, only about 15 to 20% of one's health status is determined by health care. And that's true in Europe as well as here. So even though they have a different system, a better system in many ways, so that's where our Center for Health Improvement, what we're doing at MaineHealth is we're trying to achieve our vision at MaineHealth as being the healthiest communities in America. Our vision is working together so our communities are the healthiest in America, which is a very different vision than most hospital-based healthcare systems. So that's why we have about 300, we have 25,000 employees total. We have a team of a small but mighty team of 300. Many of them are on the meeting here, who work to try to achieve that vision. And we are, as I said, we work in that nexus between public health and healthcare. So, and we have actually a lot of great data to show that we're achieving it too. We have some of the best health outcomes in the country, despite the fact that Maine is a poor state. So, anyway, and we don't have public health departments, as I mentioned earlier, across the state. We have and we serve mostly rural areas where they are challenged by a lot of things, including the lack of healthcare, poor health status, and poor demographics and the kinds of things. But anyway, Ryan Bouchard is a team member of ours. So Ryan, you've got a question.
Yeah, I think nationally, right, with what's going on with some government agencies, right, it's kind of really, I think, in some ways shown the impact that government has in healthcare, right? The CDC, for example, doing research on diseases that are very, very niche and don't affect a lot of people. And so I was wondering if you could talk a little bit more about how you see government fitting into this model. Does that make sense?
It does. I mean, I think, government, to me, there's so much to say about that. I think, given what's happening now, I think I think it's chaotic, right? Without getting political about it, I think it's really chaotic, not just in healthcare, but across the board. I was just talking to some business friends yesterday, and, the tariffs, I mean, whether you think they're the right thing or not is not so much the issue. It's just like, you can't change tariffs like on a dime. I mean, companies are, procuring sources from all over the world, and to make that change without giving them months and months of notice is I mean, every business person I know has literally been on the phone trying to figure out what to do. And I think the same thing is true in healthcare. It's just, it just seems incredibly chaotic, not very thoughtful. And again, whether you agree with it or not, it's less of the issue for me. It's more about, like, how is this happening? What's the process? What's the thought behind it? Where's the expert opinion? There's reason you think through things and checks and balances, and that to me is a little worrisome that's not happening. So there's a lot to say about what's happening. My wife, again, is infectious disease. She has a lot to say about what's happening at the CDC. Even at CMS and HHS, and obviously as an ID doctor, the notion that vaccines are being phased out and the research is being phased out is probably the most horrific thing she's ever encountered in her entire career. For me, what's also really important is that the government really sets a lot of the payment models. I mean, if you look at CMS and you look at all the, the experiments that have been happening, it really is all about payment. And I think that's where the government can play a role, can really help. What is the game? How is it played? And that's true even for, when you talk about, Medicare Advantage. I mean, it was the government that set up MA, and and even employment sponsored payment is the rules are set up by the government. There are laws and stuff. So I think for me, the most important thing the government can do now is really reevaluate how healthcare is paid for. Again, these sweeping changes around Medicaid. Again, you could argue pros and cons, but that's not so much the issue. The issue is, how are you thinking about payment? How are you thinking about public health? One of the things I've come to realize is that we have a healthcare industry. And again, kind of interesting, Dora, to your point, what we don't actually have is a healthcare system. And I think that's the difference. I think the other countries actually have a healthcare system. Right? They have a public health system. They're thinking about the health and, again, how to do that economically. We are thinking about how to grow the industry. That's I mean, sadly, and I was an executive, and you get what's the word, inculcated. You do what you get paid to do. I mean, it's just there are very few people who could not do what they get paid to do. And I was paid to get heads in beds. I mean, and no matter what I wanted to do, what I got paid to do was to help the hospital fill the hospital. And it's just, so I think that for me is the most important thing the government can do, is it can actually change the rules of the game so that, again, you can make money, knock yourself out. I mean, as long as you're making money by keeping people healthy and not waiting for them to get. I mean, for me, again, this is sort of like but we would build these shining buildings, stroke centers and cardiac centers, and my colleagues could do magical things with catheters and just crazy stuff. Valve replacements with a catheter. I mean, literally. I mean, how could you even imagine that in the heart? And yet, I would raise my hand in these meetings, and I would say, I love it. It's amazing. And if I get a stroke, I really want to come to our stroke center. But could we maybe spend 5 cents on the dollar on preventing me from getting the stroke in the first place? I don't think anyone would argue with that. I'd rather actually not have the stroke. And so are we spending? And of course, but that's not the business model. That's not how I get paid. So, what I'm saying? So anyway, I don't know if I answered your question, but some thoughts.
No, it's fabulous. Thanks. And that is, it's a nonprofit health system. A lot of our community benefits goes to this kind of public health care kind of model of care. We're out in the community. We work with all people, not just our patients. But we have $16 million in MaineHealth operational funds that are mostly counted towards community benefits, and we have about $19 million in federal and state grants that we use to run.
Hey Dora, I'd love to interview you and your colleagues. If you want to set that up, we can do that. Because I don't know enough about the system. I know a little bit. Believe it or not, I've actually been up there and visited you all a few years back.
Oh,
but
really?
It's been a long time. Yeah. I was there. I was freezing. It was cold.
We're still freezing. I know we're still
and there were more lobsters when I was there. There were a lot more lobsters than there are now. But
we've got plenty of lobsters for you if you want to come up.
Do you still have lobsters? Yeah. Okay.
Oh yeah. And we will. You definitely. Anybody comes up here like you, we definitely take you out to free dinner for lobsters and show you the Anytime you and your wife or whomever wants to come up, believe me, we can entertain you.
Actually, she's a big fan of Maine, by the way. She's a huge fan of your state. So yeah,
really?
I think if she would move here to you if we could.
Well,
why don't you invite us up? Why don't you invite us up?
But and Catherine, a colleague of mine up in the Bangor area, she's on. I know she's had her hand raised for a while, so I'm just gonna, if you don't mind, I mean, you let us know when you have to cut off. I know we've had some people have had to leave,
Oh,
but they're just
yeah.
really, we could just talk to you all day, I think. But Catherine, do you want
Thank
to
you.
share your question?
Sure. I'm a family doctor, mostly retired. 83,000 patients in Maine still have no insurance. So how do we get to universal health care like all the other countries, at least to cover everyone? You know, and I know to bring down the cost, we'd have to probably go to other models, maybe even to single payer healthcare, but how do we get at least to cover everyone?
Well, I think, I mean, you guys, there's a lot of intelligence on this call. I think, and some of you may even be more expert in this than I am, but I think it's unconscionable that we aren't. I mean, I don't understand that. I think the ACA was supposed to, solve some of that, and it has to a certain extent. But you're right. It's still an issue. I think, for me too, it's really what I've discovered over the last year, and particularly the last few months, as I look at the landscape, the uninsured, it's easy for people to say, oh, we only have a few million uninsured, whatever, tens of millions, hundreds of millions of Americans, only a few, I think the problem is much bigger than the uninsured. When I look at it, the underinsured is probably a bigger problem.
Yeah.
And, right. And so there's a thing called Alice. Have you heard this?
Oh, yeah, we use that.
Oh, yeah. Okay.
United
Oh, you
Way,
use it.
yeah.
Okay. United Way. So
Yeah.
in the state of Pennsylvania, if you could do it by state, I think I don't know if it goes down to county, but it does go down county. That's actually good to know because I wanted to go back and look it up. In the state of Pennsylvania, 40% of the families, 40% fall into the Alice category, asset limited, income constrained, but employed. I mean, that's crazy that they're struggling to pay. 40% of the families are struggling to pay for basic bills, including basic health care. And if you look at another body of literature, if you look at the people who are employed and who have insurance, so they're employed, 40% are underinsured. And again, you look at, it's not rocket science. When I have a high deductible health plan and the first, $7,000 are out of pocket, well, then for all intents and purposes, I'm uninsured for for $7,000. I mean, of course, am I going to spend money on healthcare? Of course not. I mean, and so this to me is really, really the tragedy in America. It's the underinsured. And then of course, the Medicaid population, I know it's getting smaller, unfortunately, sadly, by the moment, with potentially some of these impending restrictions, but whether it's 80 million or 90 million or whatever it is, who people are on Medicaid, significant amount in the state of North Carolina, half the children were on Medicaid, right? And so where I reside and worked for many years here, it's really, I mean, to be on Medicaid and then you're on Medicaid and then good luck finding a doctor because, I talk to private practitioners now in the state of Pennsylvania, they get paid somewhere between $25 to $30 a visit if you're a Medicaid. I mean, you can't have a practice and survive. You're losing money on every Medicaid patient. So of course they're saying, I was actually just talking to a group in Western Pennsylvania, family practitioner, and she said, we're surrounded in our county. There are 50, 60,000 people on Medicaid. We can't take them. We have to turn them away every single day. And she said, it breaks my heart. This is not why I went into healthcare. This is not what I want to do, but I can't have a business and afford the business and sustain it. And so we were actually, of course, talking to her about, we'll join our model and we'll show you how to do that. We'll show you how to make Medicaid profitable. But it is to me, Catherine, that is the bigger problem. It's not just, I mean, uninsured is just unconscionable. It's just ridiculous. And I don't know enough about the policies and mechanisms of how we can eliminate it, but I do know that the bigger issue is the underinsured, and that's also,
And 66% of bankruptcies are from healthcare in this country, and that doesn't happen anywhere else in the world.
Yeah.
Nowhere. I mean, right?
That's unconscionable too.
Right, isn't it? I mean, it's just the fact
Yeah.
that literally, what is that thing when you go online and you ask people for money? You set up an account. There's a
Oh,
name
go-
for
Oh,
it.
I know what you mean, yeah.
GoFundMe. GoFundMe.
What's that? GoFundMe.
GoFundMe, yeah.
Things like GoFundMe. It's just like when you see these things, it's just like I need surgery. My son needs cancer. Money for chemotherapy. You form a GoFundMe account. I mean,
It makes you sick.
unbelievable.
Yeah.
It does make. No,
Can
I'm
you
with
just-
you.
Can you just tell us a little bit before we end about what you were doing now? Because you said it's a Medicaid managed care, a Medicaid. I didn't quite understand what it is. Could you
Yeah.
just explain it? Because it sounds fascinating and it segues right off from Catherine's question, I think.
Yeah, so it's really interesting. The founder is a physician who's actually a black guy who grew up in the projects in Nowhere, Pennsylvania. Mom was a single mom, Medicaid, et cetera. He went to pharmacy school, and then medical school at UPenn. And his mom died because she didn't receive the treatment she should have in a hospital because she had the wrong color Medicaid card. And so he basically spent the last 30 years starting with free clinics and then Medicaid clinics. And he's a little bit of a savant, and he's the guy that studied health insurance and the mathematics and behind insurance and knows cost accounting. So he's a little bit of a genius. And anyway, he started to iterate this model, which is his current kind of version. But essentially, it's Medicaid managed care. So it's a capitated arrangement with health plans where it's a subcapitated carve out. So we provide about 15 services for Medicaid in this capitated carve out, and we own all of the assets that we need. So we don't have to pay. We don't pay for physical therapy because we have physical therapy. We don't pay for imaging because we have imaging. We don't pay for behavioral health because we have behavioral health. We don't pay for pharmacy because we have pharmacy. So we essentially cut out the middlemen. We cut out all these profit centers because we own them. And so we can lower the cost of care there. We don't have to, we don't need a big administrative staff. We have literally one billing person. Because all we need is claims, shadow claims. And so, all that administrative overhead that you need in a fee-for-service model is gone. All the profit centers I just mentioned are gone. And then we basically cost account. So it's essentially, it's a cost plus model. And so we make a margin, no question about it. But it's about when you compare us to others that are providing Medicaid fee for service, we're about 60%, 55% of the costs. And health outcomes are just as good, if not better, in terms of, all the HEDIS metrics and things like that. And what I love about the model too, in addition to this kind of comprehensive primary care plus, if you want to call it, or expanded primary care, because it's much more than primary care, we also have a position, a role, which is called a care advocate. And essentially their full-time job is to do nothing but help with care navigation, enrollment, and social determinants of health. So it's not like the nurse's third job or fourth job, or the MA's third or fourth job. We have someone who does nothing but that.
Wow.
And so, we have about 4,500 members.
I was going to ask you how many patients you have. So you have about 4,500.
Members, yeah. So they're members, and they're capitated members. We are growing by leaps and bounds because we actually have I love it. We go out into the community and go into restaurants. Your waiters and waitresses don't have health insurance. This goes back to your question on, a lot of the reason people don't have insurance is because they don't even know how to get insurance. It's so onerous. So we literally go in with our laptops into laundromats, into restaurants, into homeless shelters, into substance abuse centers. We open up our laptops and we say, we can get you insurance and eligibility. And then you just, you join out, the insurance, the health plan that we subscribe to, a couple of health plans, soon to be a third in the state. And you sign up with us, and you get all these services, no co-pays, no deductibles, no out of pocket. You join, and that's it.
And it's but they're on Medicaid, and it's in Pennsylvania, right?
Pennsylvania, we are actually, I was just having a conversation with a colleague here in North Carolina who said, could you do this here? Could you take over our community clinics? And we've already thought about that. I was my role as an attending, I practiced mostly in the community clinics in the hospital systems when I did, my clinical part. And I also, of course, ran the community clinics when I was doing my operations work for many years. So I know what the community clinics are like in our system. This is where the doctors get trained, and they're abysmal. And it's not the fault of the providers. The providers are amazing. They're some of the smartest doctors and the best doctors I've ever met. That's not the problem. It's not the staff. It's not the doctors and nurses and other staff. It's not a viable business model. And it's, as long as it's charity care, it's not good care. And, so we have a for-profit model. The doctor, it's called Gloria Gates Care. It was the company's named after Dr. Gates's mom, and Gloria Gates Care,
Right.
like Gates, Gates, yeah. And we're at the beginning. We're like any model now. He's been working on this for 30 years, so it's not his first rodeo. But we're refining the model, getting better at it, and but our goal is to go out of state. In fact, I'm having now some semi-serious conversations in North Carolina, Maryland. What's the big health plan there? They just pulled us in and asked us if we would consider going to Maryland. So yeah, no, our goal is to, it is to scale, and because it's here, this would be like you. Let's say you're in a community. You talk about being a community center. You're in a community. Let's say you have 30,000 people, 20,000, 40,000, whatever the community is. You say, we're sick of American healthcare. We're going to take American healthcare and do it ourselves. And on your team, you have a finance person, an insurance guy, someone who lives in the community who knows insurance. You got some clinicians. You got some people who have some knowledge in physical therapy, radiology. And say, how would we form something and literally cut out 40, 50% of the cost of healthcare?
Middleman.
That's what we've done.
Your model sounds like the Indian Health Service to me. I was there for 4 years, and we had the public health service model where we had doctor, nurse practitioner, lab, pharmacy, 4 counselors, home health, diabetes education, dental, orthodontia, all in one building. We
That's
all
really
worked
good.
together, and
That's
it was
great.
chronically underfunded, but it was an excellent system.
So you had more than we had. We are talking about dental. We don't do maternity either, which is a huge problem in Pennsylvania. But so we don't do a couple of things, but the difference is that we don't depend on grants. So we're not an FQHC, and we are a for-profit model. And essentially, what's really interesting, everyone talks about disruptive innovation, which is the Clayton Christensen thing from Harvard. So there's a whole I can't even say it's a counter movement, but there was a book written about non-disruptive innovation about 2 or 3 years ago by the guys who wrote Blue Ocean, the classic business book. Same 2 professors wrote a book 3 years ago called Non-Disruptive Innovation. And they talked about the fact that we've all been brainwashed that all innovation has to disrupt the status quo. So what we're doing at Gloria Gates Care is actually non-disruptive. There is no one that gets harmed. The health plans love it because we're growing their membership and lowering their costs. So their MERs are in the 80s. Their medical expense ratios are in the 80s. The hospitals love us because, we're taking their patients out of the EDs and, they could discharge to us. Other providers love us. We actually get most of our patients from primary care doctors who can't take, and actually now they want to join us. It's literally like bizarre that there is no one we're actually harming yet. I think once we get big enough, it might be a different story. But right now, it's really cool, and we're not dependent on grants.
You have to be in a state where there's Medicaid managed care. Is that right? Because we don't have Medicaid managed care, though we do have Medicaid expansion. That we've got quite we have almost 1.4 million people in Maine, and there are over 400,000 people with Medicaid insurance. Medicaid. So it might be a good place to think about it. So we don't have Medicaid managed care in Maine.
Your health plan can offer Medicaid. They can capitate it out if they want to. I think. I don't know that you.
Yeah, not sure.
I don't know that.
Right now.
Something you could look into.
It's fascinating, and I could see Ryan like soaking this up. And I'm like, okay, his wheels are going. I think some others are too. So
happy to talk to you about it. Yeah.
Thank you again. This has been phenomenal. I could
thank you.
I listened to you all afternoon, all evening. It was fascinating. Please do plan a trip to Maine. I will email you some materials, and I can't thank you enough. I know you are in
thank you.
high demand as a speaker nationally, and I think even internationally. So we really appreciate all your time today. And we had about 60 people on, except that some people had to leave the last half hour because they had other meetings at 1. But I tell you, I've been getting text messages, emails from people
Oh,
saying, "Oh my
good.
gosh, this was amazing. Thank you.
Oh, good.
Thank
Good.
you.
Thank you.
Good.
Thank you."
I'm glad
And-
I did, Dora. I'm glad I did a good job for you. That was the thing that I didn't want to let you down.
Oh, you did fabulous. Thank you so much. You
Thank
take
you.
care, and we'll see you up in Maine next time. Okay,
Yeah,
take care.
let's do it.
Thank you.
Okay,
Bye-bye.
bye, guys.